Okay? Yeah. So, this is not what, let me just move on from here. So, 2 slides on the suturing. Remember the question that was asked. So, one of the things that's very important in when you do the suturing is to, all the lines should appear one. It's a single line, as you can see over here. There was one which was not, but if you get a double contour for the line, then it's not right. But here all of them are single straight. If your line suture pass is not right, you will find a black line coming like that, then you know that's not right. So that's one point. Then if you, and this is in the context of corneal grafts, the suture should be radial. Now look at this suture here, look at this one, and look at this one going a different direction, so when that's the case, then you know you've not placed them right. They should all be radial. But this is the point I was making. That you've passed your suture and you've done your knot and you're about to bury it. What you look at is the situation here with regard to the cut the needle has made in the stroma. If that cut is in the middle of your suture, it is very easy to turn it around. But often you will find it's not. It's like this. The closer your knot has to go to the corner of that cut, that's the needle width that has gone through, it'll catch. And then you have to move this to that side and then pass it in. So always try to move your suture to the middle of that cut and then pass it, and it goes in very easily. It can be like that. That is very difficult to put in. So all these things will happen. So just pause to investigate and examine where your needle width cut is compared to the suture, and you will find that will go in very easily. And it's so easy. I mean, there's a video to show you how I was doing that. It's not going, just move it to a side and it'll go in. So moving on, alcohol delamination of the corneal epithelium. So the idea came from LASIK. It's nothing new. You put alcohol, you take the epithelium off, it leaves behind a very smooth stromal bed. The smoother the stromal bed, the firmer the attachment of the new epithelium that grows, and the less likely it is to come off. So apart from LASIK, are there any clinical other indications for this? Now when you look at the sheet of cornea that you have, epithelium that you have removed from LASIK, you will see that the alcohol cleaves at the level of the basement membrane over here. That's what it takes off. And if you look at the scanning electron micrograph, you will see multiple little holes develop, usually at the junction of 3 cells, these holes. And when you make a section of that, you will see that there are gaps between the cells. And if you look at the bottom surface of this epithelial sheet, there are little cracks between the basal cells. So it's like pouring water on a pile of stones. The water will go around the stones and make a pool or a puddle at the bottom of the pile. And that's what it does. And what it also does, this is the Bowman's zone or the Bowman's layer, and you can see how clearly and smoothly it leaves behind very nice surface. This is in high power. Of the cells that you take off with alcohol delamination, about 70 to 30% in that range are dead or alive, whichever way you want to look at it. So all the blue cells are the dead cells, the non-staining cells are the live cells. So you may have a lot of living cells or may have a fair amount of dead cells. So when you have a lot of living cells and you put the sheet back on the surface, it tends to stay live and attach. And this is the technique. You take a optical zone marker for cross-linking. There's a standard 9 or 10 millimeter marker, but otherwise you can have your 6, 7, 8 millimeter. You place that on the area of the pathology that you're going to treat. We're not talking of LASIK or cross-linking now. We're talking about for clinical uses, the use of alcohol delamination. Then you put 20% alcohol for 30 seconds. After that, you suck it out with a swab and you peel that sheet off and you put it on a piece of paper and you use that for histological examination, and I'll show you how important that is. So here it is absolute alcohol, which is 100%. You take it with a needle into a 1 ml syringe and then you take off the excess to the point. Oh, sorry, let me get this pen. I'm using my so you will take it to the 0.2 mark on that, and then you will suck water all the way to the 1. So 0.2 in 1 ml is 20%. You put it back and forth and mix it in a trough, in a galley pot like that, and then you will suck it back in the syringe and you will leave it in that in the syringe. If you leave it in the galley pot, the alcohol will evaporate and you'll only be left with water. So you do all of this, and you make your mixing before you prepare the patient. Now, when we're looking at recurrent corneal erosion syndrome, this is one of the most commonest and the most useful indication of this technique. You identify the area of positive staining, which is green, and negative staining, which is where the epithelium has lifted off the Bowman's zone or the above the basement membrane, but it is not torn. So it's not going to stain, but it's going to show you this negative staining. And that's the whole area that you have to treat. And this is a little video. You dry the eye, you put your zone marker, and then with a little bit of pressure on the cornea, not a lot, just a little bit of pressure, then you put your 20% alcohol in it, which you have prepared, and then you will wait for 30 seconds, you will suck it out, and then you will wash it. If it spills, just give it a wash, dry, and start again. But here it didn't spill, so a wash was not really necessary, but anyway, there you are. And now you can see how loose the epithelium is. It's wrinkling, just to demonstrate that. And then you take any instrument, a dry swab, a crescent blade, a hockey stick, anything, and you can gently peel off the entire epithelium, and it'll almost like a epitheliorhexis. It'll come along the circumference of that mark that you have made, and you can take it out. Then you wash it, wipe the bed a bit, put some BSS and a bandage contact lens with some antibiotic drops. Which you give them antibiotic drops, you leave the bandage lens for 2 weeks, and we take it out after 2 weeks, and that is something in the range of an 80–85% success rate in recurrent corneal erosion syndrome. They'd get no more erosions ever, and that is very, very useful. And it has other options. We have other options as well, like you can do diamond burr polishing, PTK, or anti-stromal puncture, but this has some advantages. So here's another example. This is how the patient looks on the diffuse view. Negative, positive staining, alcohol delamination is another example. Some patients of recurrent corneal erosion, you don't see clinically anything until you look for it. And if you look for it and put fluorescein 2%, dilute it, wait a few seconds, let the tear film break up, and you will see very subtle intraepithelial microcysts. That is how they look. Some of them have burst, causing positive staining. Mostly they are negative, and that can cause excruciating pain and the whole syndrome of recurrent erosion. So that's it after alcohol delamination. So what do you do with the sheet that you've taken out? That's very important. So you, on a piece of paper, you float it in BSS and you open it. And once you've opened it like that, doesn't matter it's up one way, up or down, you can't tell. And then you will suck the water out with a swab so that the sheet settles flat on the paper. And when the sheet settles flat on the paper and you've dried the surrounding water, you bring your drop of glutaraldehyde or formalin or paraformaldehyde, whatever fixative you want to use for the purpose you're going to process that tissue for. The important thing is that it lies flat and it fixes flat. And it's, then you give it to your pathologist, they will give you beautiful histology with morphological orientation. If it's a clumped up bit of tissue, it's very difficult to tell which side up, which side down, which is the basal cell, which is the epithelial cell, causes a lot more problems in interpretation. So here you can see in the recurrent corneal erosion syndrome, it is very interesting to see that the hemidesmosomes are very, very abnormal. And underneath the basal cell, there's a lot of collagen debris. So here again, you can see there's a very dense collagenous debris, and even here the hemidesmosomes appear normal, but they're not in the double line that we are used to seeing in normals, and here they're completely fragmented. So there is a reason why these cells are not sticking, because intervening between the basal epithelium and the stroma is this collagen debris, and your anchoring filaments cannot go down and grab it on the anchoring plaques. So this alcohol delamination for recurrent erosion, a very safe, effective alternative to other treatment modalities. There's no residual effect like scarring, which we always see with anterior stromal puncture. And unlike PTK, it is inexpensive and does not induce a hyperopic shift. So in PTK, you are supposed to take about 5 to 7 microns of the Bowman's layer. And if you do that once or twice, then you've gone quite a bit into the stroma. And if it is eccentric, you will create an irregularity on the surface. So you have to always align your PTK to the center of the cornea and do a large area to cover the area of the pathology. But with the delamination, you can go as eccentric as you want because you're not doing anything to the Bowman's zone. And Here it gives you tissue for histological examination, as we will see. So that is the main indication, but that's not all. There are many other therapeutic indications and diagnostic indications, as you will see. Intractable epitheliopathies and conjunctival intraepithelial neoplasia and a few others. So here's a patient following a graft. The epithelium is heaped up. It is staining negative and positive. 1 week he comes, it's like this. Another time it's like this. Another time it's like this. Another time it's like this. And that is changing. And you think this is herpetic. You're treating it for herpes. It's not going away. So all you do is do alcohol delamination, take the lot off. It'll heal back, and you never see that lesion again. And that's exactly what we did for this patient. Here's basement membrane dystrophy, map dot fingerprint. It's usually eccentric, and if it is not in the visual axis and is not causing recurrent corneal erosion syndrome, you don't have to treat it. But if it's in the visual axis, it will cause alterations in vision. The quality of vision is poor. Then you do alcohol delamination, you take it off, and you can see over here, and this was the other eye, the 2 eyes. And then when we did alcohol delamination, took the epithelium, you can see those map dots are those white dots are actually, you have basement membrane on the top. So this is duplication of the basement membrane. At the bottom, cells are trapped in between, and these cells are undergoing various stages of degradation and necrosis, and then they form those white dots in map dot fingerprint dystrophy. So this was a patient sent to me as dystrophy, as saying some kind of corneal dystrophy. We said, no, this looks more sinister than that. This is probably a CIN. So what we did is alcohol delamination. 2 things about the dystrophy. One is never diagnose a dystrophy by looking at one eye. You must always look at both eyes, even if it's banned or obvious in the exams. You make the motion of looking at both eyes. You'll see lattice and granular straight away, you can tell, but you must look at the other and then say it's a dystrophy. So here, and then we treat it with mitomycin, but I want to show you the histology. This is when you treat it the way I explained to you, and then the pathologist will give you this. And this is beautiful flat epithelium right from the basal cell to the top. You can see the top cells look normal, normal squamous cells, but look at the bottom, multinucleated giant cells. All these are signs of atypia. The only disadvantage of alcohol delamination is it doesn't give you the stroma. So to diagnose carcinoma or squamous carcinoma, you have to look at penetration through the basement membrane into the underlying tissue, but you can't tell that because you don't have any underlying tissue when you do it by this technique. So here's another patient with a presumed herpetic eye disease, a non-healing area that never healed. So then we did alcohol delamination. It completely healed, leaving some subepithelial scars. From the tissue, we could see a lot of apoptosis, marginization of the chromatin, as you see over here, and with some intranuclear inclusion bodies. This was a very interesting situation. Limbitis with epitheliitis, inflammation, a lot of vascularization. We couldn't tell what's going on. We were trying to treat it for some infections with usual, steroids, antibiotics, other things. It didn't go away, and then this you would call a pseudodendrite or whatever. So we said, okay, let's just take away all that abnormal tissue, which we did, and that's what it became. Just like that. So the medicines didn't work, so you take away all the abnormal tissue. So sometimes I call them intractable epitheliopathies of unknown etiology. You can make a big difference by then using this. But this is something we recently published, very, very useful indication for this technique. Granular dystrophy, when you have a patient whose vision is compromised, you do a penetrating graft or a deep anterior lamellar graft. But give it time, a few years, and the epitheliopathy and the dystrophy will come back in the tissue. And when it comes back in the tissue, what happens is that it is coming back mostly from the epithelium, because the turnover of epithelium is very fast. The keratocytes take a longer time to come back from the host and repopulate the donor keratocytes, donor stroma. So deep deposits of granular you do not get soon. Superficial deposits come very soon. They all are in the epithelium. As you can see, confocal microscopy and in the alcohol delaminated epithelium, a lot of these crystals or these deposits of granular are in the epithelium, and they work their way into the stroma. So if you take away the epithelium, before they get into the stroma, the graft remains clear, the new epithelium is clear, it will last 1 or 2 years, and then it will start to accumulate again, and you can keep doing this. And these are examples. You see, this is the dystrophy in recurrent in the epithelium, alcohol delamination, and we have the confocal and the histology. Here again, same thing, and it tends to deposit if you have a graft host junction there, or these are arcuate incisions, the material was, and it clears up. So we have, I don't want you to actually read this slide, but what we're trying to show is that, see, 11 years, 9 years, 10 years, 15 years, 11 years. So patients had up to 4 alcohol delaminations over 11 years. Not a single one. So we have 7 eyes from 4 patients. Not a single one needed a regraft. So you can prevent regrafting in patients with recurrent dystrophy by doing alcohol delamination on a regular basis every 2 to 3 years. A very useful indication. And there are some other things like this is Thygosons. We don't know what causes it. You treat it with steroids, it goes away, they become steroid dependent, so you need long-term steroid. But if you have a whole cluster in the visual axis, instead of giving them long-term steroids, you just do alcohol delamination and take the lot off. So this is a confocal image of Thygosons. And interestingly, again, when we did alcohol delamination, took this off, you can see there were some intranuclear and paranuclear evacuation, intranuclear inclusion bodies, suggesting that it might be viral in origin. So alcohol delamination is a simple outpatient procedure. It's inexpensive compared to excimer laser PTK. It can be used effectively to treat a variety of corneal epithelial ocular surface disorders, avoiding need for transplants in recurrent granular. And it is very useful as a diagnostic biopsy. So you're getting tissue which you can fix properly and get a lot of information. You can even use it for culture if you want, or for PCR, because you've got a whole big sheet of cells. And we have not seen any long-term complications for any of these indications that we have used it for, other than, there's about a 10 or 15% recurrence of recurrent erosion despite treatment with this. And just one little pearl, if you have a patient with recurrent corneal erosion that is not curable or treatable with any of the options you choose, be it PTK or stromal puncture, then think of herpes virus infection. Because occasionally you will find recurrent erosion in herpetic patients, and it's actually herpes that's causing it, and we are not thinking of that, and then you have to treat them with the antivirals, and that helps. So thank you very much. So at this point, I think we will conclude this part of the talk, and then Rashmi will come up and give us a talk on the amniotic membrane. But any questions on alcohol delamination before we move on?
Is it useful for filamentary keratitis?
If there are a large number of them, it will get rid of them, but it will not cure it, because this is mostly dry eye related. And again, this is my observation, it's not published anywhere. Filamentary keratitis you will see more associated with collagen vascular disorders, not with any other type of dry eye. Why that happens, I don't know, but it's quite strange. The problem is, if you do that, you will leave them with a large epithelial defect which may not heal, because in the dry environment it will not heal. So I have never tried it for that. I just go and physically pick out the filaments. Yeah.
And in herpes, like you said, there could be a confusion. So would it be detrimental if you use it
No,
in a herpetic?
it's not detrimental, only it doesn't work. In fact, if it is frank herpetic lesion or it's atypical herpetic epitheliopathy and you're not sure, the old classic treatment used to be debridement. You take away that area of epithelium, it'll take the virus load with it and it'll heal. And that is exactly what you will do with this. So if anything, it will be beneficial, but the erosion problem, the severe pain on waking and all that won't go away, and you have to then treat antiviral as well.
Thank you.
Any questions? Okay, Rashmi, you're all set. Right. So just a little tip about when you're making the 20% alcohol, you take it in the syringe, the video stopped halfway, so you take out the air, up to 0.2 mark you put it, then you disconnect that needle, because that needle is full of alcohol, and it'll become stronger. And then you suck your BSS or distilled water, it doesn't matter what, and you put it up to the 1 mark, and then you've got your 20, and then you mix it.